All right, I'm going to turn it over to Pat Ward. Special thanks to the foundation for putting this on for us today.
All right, thank you. And first of all, we're really happy to do this. For those of you that aren't too familiar with the foundation, we have 3 initiatives. The first initiative is community outreach. We will soon have 4 free adult vision clinics open in the greater Cincinnati area. Our 4th one is going into Middletown, Ohio. And we are blessed because we have the volunteer ophthalmologists that really provide the care. And then I have a staff of technicians that do a lot of the work and maintain the medical records and do the follow-up. The second thing we do is education. This is an example of what we do for technicians, registered nurses. We also do a complete program for doctors of optometry. We do 8 credit hours for them annually. We also financially support the University of Cincinnati residency program. So we have a pretty extensive education offerings. Last thing we do is research. And our next speaker is really the chairman of our research committee. We are committed to providing startup money for new ideas that offer the potential for new cures and new treatments for eye disease. So that's what the foundation does. And once again, really happy to be able to support this program, and I'm glad you're here, and I hope you have a great program. Okay, let me introduce Dr. Michael Nordlund. Now, for those of you who work at CEI, you know Dr. Nordlund is the vice chair of CEI, number 2 guy. Now, he's going to talk today about updates in cornea treatments and surgery. Doctor?
Thank you, Pat. And a little hoarse today because Shane and Sarah and a few others kept me out singing late last night. We'll get through it. But welcome, everybody. How much time do I have, Amy? 15 minutes. Okay, good. I think. So what we want to talk about today is the last 15 years. There's been this tremendous revolution in how we approach corneal disease surgically. And there's a lot of acronyms. I'm sure you guys hear these: PK, PKP, BLEK, DSEK, DMEK, DSEG, DSEC. I mean, there's all this stuff. So I want to kind of walk you through that to give you an idea of what some of that is. And it's really not nearly as complex as you think, but it's pretty cool. 15 years ago, so I finished my fellowship in 2001. And when I finished my fellowship, there was one treatment for patients that had corneal disease. If they had corneal edema, we did a penetrating keratoplasty. If they had a scar, we did a penetrating keratoplasty. So there was one surgical treatment for the multiple layers of the cornea, and we don't do that anymore. The fact is, the minority of what we do is penetrating keratoplasty. We now target our surgical correction for these patients based on the area of the cornea that's diseased. So that's what all of this revolution's been. It's been a tremendous amount of fun to enter your career at that time when this is going on, because every year we're doing something a little different. So let me walk you through what some of that stuff is. We'll start with a little bit of a review of the anatomy and physiology of the cornea. We'll talk about some of these corneal surgeries, and then I'll try and make sure you understand a little bit why we pick which surgery when we pick the different surgery. At any point, if there's questions, if I'm not clear about something, just raise your hand, shout out, do an arpeggio, something like that. So this was a picture. I don't know why it doesn't come up. All the other slides appear to be working, but it was just a picture of an eyeball, and it shows the cornea. It showed a cross section of the eye, and you see the cornea, the anterior chamber, the lens, the posterior chamber, the retina, and it's just to start the conversation. So the normal function of the cornea is to focus light in a regular fashion, and in fact, the cornea is 2/3 of the focusing power of the eye. The other third comes from the lens. So when we see disease in cornea, typically what's happening is there's some disruption of that focusing power. And there's either distortion or there's cloudiness with dispersion. And so as a result, patients don't see well. when we look at the cornea up close, at a microscopic level, there are 3 functional layers. You've all been taught about the 5 layers of the cornea, I believe, and we'll talk about all 5, but really there are 3 functional ones when it comes to our decision about making surgical correction or evaluating disease. So starting from the outside in, there's an epithelium. The epithelium is a structure that covers, we have epithelium on every external surface of our body. And it's constantly regenerated. This is one of the features of all epithelium. And the reason we do that, this is the part of the body that is exposed to the environment. So it's under constant stress. And so you turn over your skin, you turn over the surface of your eyes, you turn over the lining of your gut, because these are areas of direct contact with the environment, and there's constant micro-trauma that occur. So this is a self-generating layer, and it comes from the peripheral portion of the cornea. So all the way around the outside of the cornea, we call that the limbus. There are these specialized cells that will divide, and then epithelial cells will grow sideways up onto the cornea. As they do that, they become flatter and they become thinner, and they lose a lot of their cytoplasm. So this is the epithelium of the cornea. You can see it's maybe 5 cell layers thick. It's very, very regular. This is a constantly replaced structure. It is attached to the bulk of the cornea. So this central portion is primarily collagen. So you see very few cells in this portion of the cornea. So that's the stroma. It is primarily collagen. It is structural. But it's very important that these collagen layers be organized in a very regular fashion in order for light to pass through and be focused in a regular way. So to attach the epithelium to the stroma, there is this condensation of connective tissue we call Bowman's membrane. It's an important layer in the OR because we can kind of see it when we're messing around with the epithelium. And if you get below Bowman's, then the stroma itself is much less condensed, so it's more raggedy if you're down into those layers. So that's a condensation that holds the epithelium in place. On the other side of the stroma, we have a condensation of connective tissue called Descemet's membrane, and it holds the endothelium. And the endothelium is a single layer of very flat cells, and they have a super specialized function. So on the outside of the eye, we have tears. On the inside of the eye, we have aqueous. Who knows why our eye makes aqueous? So the cornea has these cells in it. They're all living. They all need oxygen. They all need nutrients. The lens is primarily protein but has epithelial cells. Those are living tissues. They need oxygen. They need nutrients. Where do our tissues get oxygen and nutrients? From our blood. But there's no blood supply to the cornea, which is why light passes through clearly. There is no blood supply to the lens after you're born. So in order for these structures to get the nutrition that they need, the ciliary body in the back of the eye creates aqueous. Aqueous is full of all sorts of nutrition. It's got the electrolytes that these cells need to survive, and it passes around the lens, bathes the lens, it passes through the pupil, and then it drains out of the eye. And when it does that, it nourishes the cornea because it's constantly circulating. So there is aqueous in the eye, and that aqueous, there is hydrostatic pressure that wants to drive fluid into the stroma. And I've told you that the stroma isn't clear if the spacing of all those collagen fibers are not regular and tightly packed. So if fluid moves into the stroma, the cornea will swell up. That organization is disrupted, and you have cloudy vision. So that's corneal edema. And to prevent that, we have endothelial cells. And these are like sump pumps. So groundwater wants to seep into your basement, and you have a sump pump that constantly pumps it out. Same thing happens with the endothelium. So if the endothelium goes bad, now you have fluid flowing into the cornea and you don't see well. So those are the different layers. Those are the structures. This layer is constantly replaced. This layer slowly turns over. Over 20 years you get remodeling of the cornea. It's never fully replaced. So you can think of this as pretty static, but there is wound healing that can occur in the cornea. And then the endothelium does not replace itself. We are born with a fixed number of cells. So if I were to count these cells and all of you, when you were 10 years old, there might be 4,000 cells per square millimeter. And by the time you're 65, you probably have 2,500 cells per square millimeter. And if we all lived to be 150, everybody would have corneal edema because we wouldn't have enough cells. All right. Three functional layers of the cornea. We talked about the surface cells, we talked about the stroma, we talked about the endothelium. Those are the layers that we fix when we do surgery. So there are abnormalities of the epithelium. They tend to be either genetic or traumatic, chemical burns or autoimmune, and they affect the cells that create the epithelium. And we're not going to talk about those today. Those patients require stem cell transplantation, and I think it gets beyond where we really want to be for this conversation. But there are disorders of the epithelium where you can't make enough epithelial cells, or you make the wrong kind, and then you don't see well because your surface is not nice and smooth. And so there are ways to fix that. But more commonly, we have conditions where the epithelium isn't sticking down to Bowman's membrane very well. So you can have recurrent erosions, you can have basement membrane dystrophy, and so again, you end up with a lumpy, bumpy surface, and we can fix that by doing what we call a superficial keratectomy. So when you hear the word keratectomy, kera is Greek for cornea, and tectomy, you're removing something. So when we say penetrating keratoplasty, you're remodeling the cornea. So that's what that prefix means. We're going to talk about superficial keratectomy and how we do it. We're going to talk about deep anterior lamellar keratoplasty, which is a procedure where we're just removing the stroma. And we'll talk about different endothelial procedures, and we'll talk about the tried and true penetrating keratoplasty, and even a new, over the last 15 years, we also do some plastic or keratoplasties, and we'll show you some of them. So in superficial keratectomy, we showed you this, I'll go back real quick, we showed you this normal structure. You have stroma, nicely organized. You have Bowman's layer, which is hard to see here, but it's this condensation of connective tissue. And then you have the epithelium nicely sitting on there. And if that epithelium doesn't stick down well, and maybe it doesn't stick down well because it's an inherited or a genetic predisposition, or maybe it doesn't stick down well because you scratched your eye, and when you did that, you damaged Bowman's membrane, and now there's difficulty for the cells to stick in place. So what happens is these cells will periodically come loose, and then they make more basement membrane material to try and reacquire adhesion. And when they do that, you end up with these bumps, these deposits. So you end up with a lumpy, bumpy surface. So here, this is Bowman's membrane. It's very translucent. And then you have these big deposits, which are either within the epithelium or right underneath the epithelium. So recurrent erosion syndrome, these patients have a scratched eye. It heals, but then the next day they wake up, and as they do that, their lid drags across the surface of this loose skin, and it pulls it loose again. And this can be a recurrent, ongoing problem. And it can be very difficult to make it better. Basement membrane dystrophy, where it's related to dry eye, and as we get older, you can just have inherent difficulty with adhesions that make these cells come loose spontaneously. And then Salzmann's nodular degeneration is where you kind of get a callus that forms between the epithelium and Bowman's membrane. These can all be addressed with a superficial keratectomy. And what we're doing in that procedure is we're removing the epithelial cells. And we remove maybe the central 6 or 8 millimeters of them. And we make sure we polish down to Bowman's membrane so everything's very, very smooth and very fresh. And then we wait for these cells to grow back. Remember that they're regenerating, they grow from the outside in. And when they do that, they will, again, more often than not, become adherent in a way that they don't continue to have their problems. So these conditions can cause pain or vision. The reason we fix them would be to either get rid of this recurrent discomfort or to improve the vision. Questions about superficial keratectomy? I typically do this in the office unless, at the microscope, unless the patient just really can't sit still. And then, occasionally we'll take these cases to the OR. So, superficial keratectomy, that's epithelium. Now we're going to talk about stromal abnormalities. And there are a number of conditions that cause problems with the stroma. And again, if you went back 15 years ago and you had a scar in the stroma, or if the stroma was irregular, you replaced the entire cornea. Now when I say the entire cornea, typically it means the central 8 millimeters, but you trephinate through the epithelium, you trephinate down through the stroma, you trephinate all the way through the endothelium, and when you take that corneal button off, you're looking into the eye and there's nothing left between between you and the lens in the iris. That's penetrating keratoplasty. We call it penetrating because you've penetrated all the way into the eye. Deep anterior lamellar keratoplasty is a procedure where we're going to go down as far as we can. In the ideal scenario, you're going to introduce an air bubble. All this is a cross-section of the cornea. This is the anterior chamber. You're seeing the iris here. And so you're introducing a cannula or a needle deep into the stroma, and we're injecting an air bubble. And what we're trying to do is to force the decimase and endothelium away from the stroma. About 2/3, 3/4 of the time we can do this. And so now the endothelium is pushed back, and it gives you the ability to come in and remove all of the stroma in the central 8 millimeters of the cornea and leave decimase in the endothelium. And it's pretty cool. When you do this, it looks like you're looking right in the eye. You can't see. This tissue is so thin. It's about 10 microns thin, and it's completely transparent. The only way we know that it's there is we put a little air bubble in the eye, and you can see that the air bubble's not coming out, which it would obviously do if it was just fluid. We'll show you that. So once you do this, what happens is you've got this donor in place. Typically, the epithelium on the donor is pretty ratty, but it doesn't matter, because remember, you're going to create new epithelium which is going to grow across the surface. So you'll have the host epithelium will ultimately repopulate. The stroma will, with wound healing, become adherent here. And you've never had an open sky, so the eye pressure never goes to zero. When the eye pressure goes to zero in surgery, there's a risk for a condition called a expulsive choroidal hemorrhage, where the choroid starts, because the pressure is so, the blood vessels in there start to expand and they rupture, and then there's no resistance to the expansion of the wall of the eye, and it starts to push all the contents out of the eye. And your risk for that with this is almost zero. So this is a safer surgery to do, which is one reason for wanting to do this procedure. So we use it for patients who have stromal abnormalities, and the most common of these are going to be people who have scars, prior bacterial infection, maybe from a contact lens, herpes simplex virus, scars in the cornea, or in keratoconus, which is say an inherited or genetic predisposition of an abnormality where the cornea will thin. So let's talk momentarily about that. So keratoconus is this non-inflammatory thinning, so you lose stroma. As the cornea becomes more thin, it becomes disshaped, and it starts to become pointed instead of nice and round. So you see how this cornea is kind of pointed, and it's because there's thin areas here allowing the cornea to bulge. And when that happens, your vision stinks. So you'll get nearsighted, and you'll get a lot of astigmatism. The problem with the astigmatism is this is a keratometric map of a patient with keratoconus, and you can see that the refractive error here is extremely different than the refractive error here. This is telling you the shape. So this is very flat. This is very steep. You can't make glasses that give you good vision when you have that kind of variation. So these patients become contact lens dependent, and typically a hard lens. And then if those hard lenses stop working, then we have a bunch of special keratoconic contact lenses that are there to mask this irregularity, and this condition tends to continue to progress. Good news for patients with keratoconus is there are now treatments that help prevent the progression. So if you can catch these patients early and you can treat them with collagen cross-linking, you don't have to have this corneal transplantation procedure, because we can usually make it so that they don't get to a point where they won't see well. So keratoconus, you get this nearsightedness, astigmatism, and it's because the stroma is abnormal, and DALK, or deep lamellar keratoplasty, is the preferred procedure in these patients. So this is the procedure. Again, we're trephinating down. You're not going all the way through. You're trying to get 60, 80% with that initial. This is just a marker, so where we know we're going to put our stitches. And what we're trying to do here is dissect deep enough that we can introduce a cannula very deep in the stroma, so that when we inject air, it will push decimase away. And now, inside the eye, decimase is pushed down, and we still have all this stroma. And this is still a difficult portion of the surgery. You need to remove all that stroma without accidentally damaging Descemet's. Here we're putting a small air bubble in the eye, and we do that because, again, when we finally get down to those deep layers, the only way to know that Descemet's is still intact is, in fact, that the bubble won't come out of the eye. You can't see it. You see what I'm talking about. So these are stromal layers. There's air in the stroma, which is why it kind of looks frosted. Here we're piercing through the last little bit of stroma. Remember that Descemet's is pushed back, and we're injecting a little bit of viscoelastic to get some space so we can introduce the scissors and remove all this overlying stroma. And you can see the air bubble in the eye, and it's not coming out. Well, it depends. So, you know, in a really good day, 45 minutes to an hour. This dissection can take a long time or a short time, just depends. But you saw how clear that was. You're looking right in the eye, and we just know that the Descemet's there. So we're taking the donor. We remove all of Descemet's from the donor because we don't need it. We don't need the endothelium because the patient has their own endothelium. And then we suture the cornea in like we would if we were doing a penetrating keratoplasty. So the benefits of this procedure, again, we don't have that open sky, so it's safer. And I had a patient who had some mental retardation. They had keratoconus. We did penetrating keratoplasty in his eye. This was before we were doing DALC in 2001, 2002. And he's a big eye rubber. He came in the day after surgery, and he had rubbed his eye all night long, and there were like 4 or 5 broken sutures, and his chamber was flat. So we had to take him back to the OR that day, put in more sutures, and then, you know, like restrain him so he can't rub his eye. We did his other eye, like 5 years later, we did DALC. So he doesn't have a full thickness trephination. He rubbed his eye, same thing, came in, there were a bunch of broken sutures, but the chamber was formed, the eye was perfectly normal, so it resisted all that. He rubbed it hard enough to break the sutures, but not hard enough to disrupt the endothelium, so as a result, the eye stayed intact, his pressure never went to 0. I could take him to the procedure room and just put in some additional sutures. I didn't have to go back to the OR, and he didn't have a risk of endophthalmitis or expulsive hemorrhage. The other real reason for doing this, though, is that the primary reason that full thickness transplants fail over time is sort of a slow, indolent rejection, and the most antigenic component of a transplant, the thing that drives an immune response the most, is the endothelium. So if I can do this surgery in a young keratoconic, 30-year-old keratoconic, and not give them somebody else's endothelium, I can leave their endothelium in place because their endothelium is normal, then their risk of rejection long-term is less, and the survival of these corneas can be longer. And so we don't have 30-year data on this, but if you look at, this is just cell counts of DALK versus PK. And again, if you're not having an immune reaction to somebody's else's corneal endothelium, you're going to preserve cell counts. And so cell counts tend to be higher for DALC. The other reason is if I'm doing full thickness transplant in a 30-year-old and my donor is 50, 50-year-old people have fewer cells, right? We're losing them naturally. So you're giving a 30-year-old a 50-year-old cornea. Hard to find 30-year-old donors because most 30-year-olds aren't dead. So typically, most transplants are of corneas that are in your 60s. Like we get corneas, they're typically 60-year-old corneas, 70-year-old corneas, and they're fine corneas, but there aren't that many 30-year-olds that are having their eyes harvested. So higher cell counts, but this is the issue here. So this is the survival rate, Kaplan-Meier survival curves of DALK versus PK, and you can see that there is a higher survival, and we think it's because of this endothelial issue. So why not do it all the time? Well, it's technically challenging. You asked the question, how long does it take? It could take you an hour and a half to get through that dissection. Sometimes there's such adhesion between stroma and Descemet's that you can't make that separation. No matter how hard you try, you really can't get it to separate, and as a result, you just have to, in trying to do it, Descemet's tears, you have a big opening, and so now you just have to convert to penetrating keratoplasty. And then we don't have the 30-year data. I saw a hand with me.
I'm Andrew.
Yeah. We would never use, so the question was, for partial thickness, could you use, I think if I understand the question right, could you use someone who's had a transplant, a full thickness transplant as a donor?
No, so like somebody's had a full transplant before.
Okay, and it failed?
Part of it is failing, would you be able to-
Yeah, so when transplants fail, it's usually because the endothelium goes bad. So the question is, could you do a partial on somebody who's had a full thickness transplant? So if someone's had a full thickness transplant and it fails, usually the reason it fails is because the endothelium goes bad. And yes, you can just replace the endothelium, it will show that. Yeah, good question. But you would never use a patient, anybody who's had a transplant would never be a donor for a corneal transplant. All right. So that's how we fix the stroma. What about the endothelium? So this is actually the most common surgery we do, right? Is the most common reason for doing any kind of a corneal transplant is because of endothelial failure. The most common forms of endothelial failure are Fuchs dystrophy. This is an inherited condition where your endothelium goes bad just on its own over time. We'll talk momentarily about it. But the other common reason for doing this is patients that have had lots of surgery or they haven't had good surgery. So a bad cataract surgeon will go in, and while they're taking out your lens, they will beat up your endothelium, and 5 years later you need a transplant because they've knocked out enough cells that you're not blurry right away, but over 5 more years you lose enough more additional cells and now you don't see well. Or you have chronic inflammatory conditions or glaucoma and you require multiple surgeries. So you have a tube in your eye, you've had a trab. Those things, just over time, the endothelium doesn't survive. And so these are the reasons that we would go in and fix someone's endothelium and why they go bad. So here, the idea is to just replace the back layer and allow, because when that back layer goes bad, what happens? Cornea swells, you can't see, and if it swells enough, those eyes will look, a really swollen cornea will look gray or light blue. You probably have seen patients like that. And they'll blister. And so patients will come in complaining of a chronic foreign body sensation, pain. And so we have to, we could do this surgery to make them see better. Sometimes if their eye is not seeing well because they've got retinal issues, we'll do it just so they're not uncomfortable. So you can do this surgery and say blind and really poor vision eyes if they're terribly uncomfortable. So the benefit of the surgery relative to, again, 15 years ago, we had to replace the whole thing. The problem with replacing the whole thing is when I take someone's cornea and I slap it on your eye, it's going to heal in a very unpredictable way. You might start out nearsighted, and I put this cornea in there, and you can end up way more nearsighted, you can end up way farsighted, and you can end up with tons of astigmatism because you're trying to get someone else's cornea in your eye. They're different thicknesses, and it's healing, and it's going to scar in ways that are unpredictable. And so the refractive outcome following a penetrating keratoplasty, probably 20% of people require a hard contact lens to have good vision. And you can end up very anisotropic, right, where your eyes have very different prescriptions, and you can't wear glasses, and you just don't see well. A good outcome with a penetrating keratoplasty is 20/40 vision. Now, there are people who have 20/20. But a good outcome would be 20/40 vision. And with these endothelial surgeries, we're not changing the shape of your eye. It's a very, very predictable surgery. We're making cataract-sized incisions, which don't really have that much impact on the integrity of the eye, so they're structurally more sound. And visual acuity is good. With DSEC, we're trying to get 20/25, 20/20, and with DMEC, we want to see 20/20, 20/15 eyes. So it is not only do you heal faster, but you see better, the quality of your vision is better. So patients who've had a full thickness in one eye and with a contact lens are 20/20, and they've had one of these procedures, and let's say they're 20/30 in the eye that had the newer procedure, will tell you that the eye that had the newer procedure has more comfortable, better vision, even though they can read further down the chart with their full thickness eye. And the reason for that is there's all these higher order aberrations which aren't measured by Snellen visual acuity that disrupt their vision. And so the quality of your vision is always better if you can leave their stroma in place, and their stroma is normal. Obviously, if the stroma is diseased, you can't do that. All right. Yeah?
For cataract surgery after partial or full, is there different protocols?
Well, so the answer is it's the same surgery. There are some like making your incision. You have to kind of plan that a little bit more because there may or may not be enough room to do that. You may have to make a scleral tunnel. The big issue with that is you just want to be super extra careful that you don't stress the endothelium, or you stress it as little as possible. So with really meticulous cataract surgery, you're probably going to knock out 5% of your endothelial cells. You just can't avoid that. There's fluid running through the eye, there's air bubbles, there's stuff, so there's inflammation. So what you don't want is a 20% reduction, right? And so there are a number of things you can do, but take your time. Make sure that you keep the eye full of viscoelastic, and if it's starting to come out, because that's protecting the endothelium while you're doing the surgery, protecting it from the fluid, protecting it from lens particles, lens chips, air bubbles, things like that. So you just want to take more time and be more gentle. You should do that on every surgery. But if people, often if they've had a transplant, the corneal surgeon will be the one that does the cataract. Not always, but often. And if you can, we'll do them like with endothelial keratoplasty, we'll do them together. We'll take the cataract out first, then do the corneal portion of the surgery all at one time, and so that way that tissue has never been exposed to a cataract surgery. So Fuchs dystrophy, this is the number one indication for corneal transplantation. It is an inherited disease. It's an autosomal dominantly inherited disease, so if your parents have this, each child has a 50% chance of having it. And what happens in these patients is the number of endothelial cells they have decreases more quickly than it would in a normal patient. So it can present in 40s, 50s, 60s. Typically what patients will complain of first is that their night vision gets bad. And the reason for that is when the endothelial cells are lost on a patient with Fuchs dystrophy, they leave behind these little protein bumps. So when down here, this is not a perfect, but this is the endothelium, and you can see these bumps. These are called gutata. It's a Greek word for drop, because it looks like little drops on the back. And if you look here, you see this sort of frosted appearance in retroillumination. That is a confluence of all these bumps coming together. And so it turns your cornea, even before it's swollen, to the back layer becomes frosted. So it's more like a window you would see in a laboratory than a window that you'd have in your kitchen, right? You have that frosted window, so it's kind of like looking through wax paper. Not so bad that they can't, again, they might be able to read 20, 20, 20, 25, but you hit them up with a light, and it's like having frost on the windshield of your car, just blinds you so they complain of night driving. So Fuchs dystrophy, they lose cells, they get these bumps, and that's actually, at this point, is the number one reason we would do the surgery in a Fuchs patient, is because they're still seeing okay if the lights are dim, but at night they don't see well because the headlights are coming at them. So often it's before they even get swelling. But if this continues, you lose enough cells, and then what happens is they'll start to notice that when they wake up in the morning, the vision's blurry. Now, why is their vision blurry in the morning? And the answer for this is it's interesting. So the cornea has these endothelial cells, and we talked about they get their nutrients from aqueous. They actually get their oxygen from diffusion from the air. So when your eyes are open, your eyes are breathing. And when your eyes are closed, you're starving for oxygen. So if you get to a point where you have just enough cells to keep your cornea clear when they're working full time, everybody's pumping full time, and now you close your eye for an extended period of time, sleep, you starve the eyes of oxygen a little bit, so these endothelial cells can't pump at maximum pumping capacity. And so they're pumping, and they're pumping as fast as they can, but with a limited amount of oxygen, it's slower, so when they wake up, their cornea is swollen. After they're awake, they start breathing, they start pumping, everything gets better. And then that period of time where their vision is blurry goes from being 30 minutes to an hour to 2 to 4 to all day. So that's the later phase of Fuchs dystrophy, and again, we fix this with endothelial transplant. So why do we do endothelial transplants? Much, much safer surgery. There's no open sky, right? We're making a cataract-sized incision in most of these patients. So when they're done, they have a much stronger wound. Patient who had a penetrating keratoplasty, all healed up, sutures out, they've had it in their eye for 15 years, sweeping their kitchen, put the broom over here, reach down to get the dustpan, and that broom falls and hits them on the side of the eye. That cornea is going to pop out. 15 years after. These adhesions that you get in the cornea Remember I told you, it heals so slowly. So if I were to do an incision in your skin, I put stitches in, they stay there for 7 days, we take it out. You put the stitches in for a corneal transplant, they're there for 3 months before we even begin to take them out. And it takes 12 to 15 months to get to where you can get all the stitches out. And it's still only probably 20–30% as strong as it was before you did the transplant. And 15 years out, it's not even half as strong as it would have been if you hadn't done it. So this happens. These patients will have incidental minor traumas, and their graft will dislodge, and it can be a blinding event. Yeah.
Can you leave the stitches in?
Well, you can. We try and take them out for 2 reasons. One is that they alter the shape of the eye, and so we're trying to get the eye to round up as much as we can. So we're taking them out in a strategic fashion to maximize roundness and vision. But the other issue is after about 2 years, they start breaking. And that's just because ultraviolet light will beat these things up, and they're very, very small. They're thinner than a human hair, these little stitches. And so they ultimately have to come out because they just break. Yeah.
How is this working with the new raindrop procedure that they had?
The new raindrop procedure for transplant.
It's almost like a camera inlay.
Yeah.
or whatnot.
But
Are they allowed to have them?
who?
People with
With-
keratoconus and...
Well, it wouldn't help keratoconic patients. So that's a refractive procedure to try and improve near vision, and you would only do that in patients with like normal vision potential.
Yeah, so are they not allowed to have them if they have this problem going on throughout?
Well, if you have Fuchs dystrophy and you fixed it, by replacing the endothelium, the rest of the cornea is normal, and those are put in the stroma. You could still have it. Patients who've had, more, penetrating keratoplasty or Dow, their vision's not at a level where they're going to pay extra money to have. It won't give them the benefits that it would give a normal eye. But a Fuchs patient who's been fixed can have perfectly normal vision. Or a patient who's had cataract surgery and the endothelium went bad, you can get them back to perfectly normal. They would be a candidate for that. So, stronger wound, if that same patient has an endothelial procedure, they get bumped in the eye, it's not going to do anything. Again, I told you the shape is very predictable. We're not going to change the shape of your cornea when we do these surgeries, where we definitely will if we're doing a full thickness transplant. They heal much faster. 2 to 4 weeks after surgery, these patients have legal driving vision versus 12 to 15 months. The quality of their vision is better, and then there's less rejection, and we believe that the transplants will last longer. There is a learning curve. There are challenges. Yeah?
So with Fuchs, does it always get worse and cataract is normal? Or?
Yeah, if you have Fuchs dystrophy, it will slowly get worse, and if you live long enough, it will disrupt your vision.
So is it will you do surgery when it's not visual so just
No, it's like cataract, right? There's not a benefit. If you don't have a vision problem, the insurance won't pay for it. But if you wanted to pay for it, the question is, well, why would you do it? Like, what's the benefit of taking out a cataract before it causes a problem, right? You're just inducing a risk that they don't really need. Now, if they have a high glasses prescription and they want to get rid of it for cataract, that's refractive lens exchange. There could be some value there. But if let's say you're somebody who has early cataract, but you're 20/20, you drive the way you want to drive, you read the way you want to read, you can do everything you want to do. You don't even know you have a vision problem. You go in, your eye doctor says, well, you've got some early cataract. It's a mistake to take that out. You're not solving a problem. If something goes wrong, 1 in 1,000, 1 in 3,000 patients can get an infection. You've just made their life worse. Same thing with Fuchs. If they have the condition, I wouldn't prophylactically fix it until they come in saying to me, I have a problem, I need you to solve it. And that's how the insurance would look at it anyway.
So is it easier to do it sooner than later?
It's not. So that's a really good question. So the answer to that question for cataract and corneal surgery is, yes, it's easier if you do it sooner than later if you're talking about way later. Like if you're going to wait till you're 102 and you've got a black lens, it would have been much nicer to do this 15 years ago. Fuchs dystrophy is the same. As the cornea gets worse, like here you can see how irregular the surface is. This is someone who's had an endothelial keratoplasty. The graft is dislocated. This is aqueous in between their cornea and the graft, which is inside the eye. So the cornea is really, really swollen. So if you wait till you have end-stage disease, it's just hard to see because we have to look through that cornea. So then the surgery is technically more challenging. But long term, if you get the surgery done properly, the patient would see just as well at that later stage, at the earlier stage. Most people get it when it's long before that. Yeah, Chris?
With fixed issues, that causation issues with the stroma?
Well, the stroma swells, right? So what aqueous, it's like a sponge. So you have this hydrostatic pressure, the endothelium's pumping the fluid out, and now the endothelium's not doing that, so it will swell. Now, early on, when they just have a bunch of bumps, bunch of guttata, the stroma can be perfectly normal, but the frosting of the back of the cornea is making their vision blurry. Did everybody hear that question? Does Fuchs affect the stroma? There's no actual, Fuchs disease doesn't have a direct impact on the stroma. It's secondary because of the swelling that occurs because of the endothelial dysfunction. The sump pump's not working. So this is the endothelial procedure this is the preferred one. Now this is DMEC. And DMEC is Descemet's membrane endothelial keratoplasty. And it's different than DSEC, which is Descemet's stripping endothelial keratoplasty. The names here stink, and the reason that they are the way they are is because they were, as this surgery has evolved, they've been named in ways to differentiate them from prior surgeries. But the name itself might not be all that inherent as to what's going on. But let me go back one slide. In Descemet's stripping endothelial keratoplasty, you are taking the endothelium on Descemet's and a little thin piece of stroma. And that's because when we first started doing the surgeries, the way you would prepare these is you would use a microkeratome to cut off the front of the cornea, but you couldn't go all the way down to Descemet's, and so you were left with a pretty thick piece. So you would have Descemet's and the endothelium here, and then there would be a thin layer of stroma that could be anywhere from 50 to 200 microns thick. So it's a much thicker piece. This is how it would look in the eye, and you don't see quite as well because the stroma is up against the back layer of the cornea, and you get a little bit of fibrosis in there, and so it's not quite the same clear vision. But it's much easier to do because when you have that stroma on there, it's connective tissue, it's collagen, it has shape. So if you were to take a donor for DSEC, which has got 100 microns of stroma, and I were to pick it up with a forceps, it would hold its shape. It would be like a cup. It wouldn't collapse on itself because it's got some thickness to it. Where when we do DMEC, there is no stroma. It's like the Doubt procedure where we've removed just Descemet's and the endothelium, and when you pick it up, it's like wet tissue paper. It just folds all over itself, and you'll see that. So this is just a much thinner version of this, and this is the preferred procedure for many people. Not everybody does it because it's technically much more challenging to work with these real flimsy pieces of tissue than it is something with Descemet's. But you do, I think the clear consensus among cornea docs is this is better than this with regard to visual acuity. You get better vision, but it is more work for the surgeon. So let's see this procedure. So what we're going to do, this is the preparing of the donor tissue. Now, one of the great things about the United States is we have these really wonderful eye banks, and it's now the case that this portion of the surgery, the preparation of the donor tissue, is done at the eye bank. So you don't have to spend time doing this in the OR, which is really nice because in the OR, if you're preparing the donor tissue and you screw it up, you got to cancel the case. So we know these tissues are coming. If they screw it up in the eye bank, they get another eye, or they call you the day before and they say, we're not going to have tissue for you tomorrow. So you still cancel the case, but you don't have a patient blocked on the table ready. So this is nice that we don't have to go through that stuff.
Since the cornea is avascular,
Yep.
how do they keep it healthy? I mean, even though.
Yeah, great question. So it can be stored for up to 2 weeks in a solution called Optisol. It has all these nutrients in there, and the volume is about 50 cc's, which is enough to maintain all the nutrition you need for 2 weeks. It's a slowly metabolic structure, so it's not like a kidney that you got to get it out and get it right in. You have this delay. And then the material itself has enough oxygen in it that it keeps everything healthy for that 2 weeks. We prefer it not be 2 weeks old when we transplant it, but the earliest you can transplant these corneas is probably about 4 or 5 days because there are all these regulations, which are good, FDA regulations about how you have to test the donor, how you have to screen the donor to make sure that this tissue is not going to transmit disease. And then, of course, there's functional tests that you need to perform. But to run all these laboratory tests, which now have to be like PCR-based DNA tests for AIDS, hepatitis C, hepatitis B, syphilis, West Nile virus. I mean, so there are all these things that have to be screened in order to know that this isn't going to transmit disease. And it just takes 3 to 5 days to get those results back. So it can't physically be released before that. So a fresh tissue would be 4 or 5 days, and a longer one would be 2 weeks. Most of the time, we're doing them somewhere between 7 and 10 days. So this is the procedure. So again, this part would be done in the eye bank. This is the cornea is upside down, just stripping the periphery. And now he's grabbed the Decimase with a forceps, this is not me, peeling Decimase away. Again, you can't really see it, right? Because it's transparent, it's so thin. So we're going to stain it with some blue dye. This is called trypan blue. And you can see how it kind of just collapses on itself. Now when he picks it up, it's just like a wet noodle. I mean, it doesn't have any shape to it at all. Wet tissue paper. It's inserted into an injector. These are IOL injectors. And then we can sort of push it into the eye. And then we have to tease it to make it unfold in the right orientation. If you put it in there upside down, it's not going to work. It's not going to stick. And you can't tell what's upside down and what's not once it's in the eye. So you have to know the orientation before you put it in, and you have to maintain the orientation as you're unfolding it. And if you lose that, it can be very, very difficult to figure it out. But if you then get it up into place, we stick an air bubble in the eye, pushes the Decimase up against the cornea, and then we have the patient go home and lay flat looking at the ceiling, so the air bubble kind of holds it there. And then within 2 weeks, they have normal functional, well, they're not always normal at 2 weeks, but they see really pretty good at 2 weeks. It takes about a week for the air bubble to go away. So that's endothelial keratoplasty. Tried and true. This is the standard, this was the gold standard 15 years ago. It was the only surgery. Here's where we're doing a full thickness transplant. We're removing the central 8 millimeters, putting a new one in, suturing it in place. And we still do this, but we do it for people who have both stromal and endothelial disease. You have to have a scar and endothelial dysfunction, or you have to have keratoconus and endothelial dysfunction. If you just have one, we're going to try and do the other. And then the other time that we would do it is if you're trying to do that deep anterior lamellar and you tear Decimase while you're doing it, you would convert to a penetrating keratoplasty. But now this is probably 15% of the transplants we do. And it's an issue, right, for our fellows, because we have cornea fellows that come, and it used to be they leave with lots and lots of corneal full thickness transplants, and now it's hard to find enough of these cases to really get them skilled at those cases. And it's a completely different skill set than these other surgeries that we talked about. And it's only going to get less and less common. There are people who don't qualify for any of these. And the reason is their eye is, there's so much dysfunction of the cornea. They've had so many transplants that they constantly reject these. There's been so much disruption of the ocular surface that they can't maintain a normal surface. And for these people, you can put in a plastic cornea. Now, this is really rare stuff, and you probably don't need to spend a lot of it, but I just want you to see what it is. And what you're seeing here is a plastic cornea that's assembled through a normal cornea transplant and then sutured into place. But the benefit of this is that this stays clear forever. So it's like a hard contact, it's like PMMA. And so for people where you can't keep them from rejecting, you can't reject the plastic, right? There are all sorts of complications, and I'm not going to go into all those details because we're running low on time, but for the very needy patient, you can achieve pretty good vision. So here's a patient that has tremendous scarring on the surface. They've got endothelial dysfunction, but all of this blood vessel growth around the limbus is such that if you did a transplant on this patient, it would be dead within 6 months. So you could try and do what we call a limbal stem cell transplant, where you replace stem cells out here so that you can get a normal epithelium. But if it's certain kinds of patients with chemical injury, Stevens-Johnson syndrome, or those patients can't tolerate the immunosuppression required to do those surgeries, then you would potentially do one of these keratoplasties. And you can't.
Does that affect their eye pressure?
What's that?
Does that affect their pressure of their eye?
Yeah, so all full thickness transplants and these keratoplasties will often induce long-term glaucoma, so make the pressure go up. The biggest issue with these is you can't measure their pressure using a tonal pen or an applinator because it's plastic, and when you hit it, it'll tell you the pressure's, it's just, you can't do it. So you're no longer able to monitor pressure the way you normally do. We have to do it sort of by palpation and just follow their nerve pulse. So if we're going to do these surgeries, we would typically, if not before, shortly after, have glaucoma put a tube in to make sure their pressure, unless their eye is real soft, because we know that like 70% of them will develop glaucoma. But the point of this slide is it's a little bit busy, but you can get good vision, 20/50, sometimes 20/25 vision. It is a lot of work to maintain these patients. This is not a panacea. You would never want this surgery unless you had to have it. And if you had to have it, you have a very unfortunate circumstance. But if you do have to have it, it is way better than being blind, and we can get decent visions with it. Yeah.
How much do those prostheses cost?
$5,500.
And insurance covers it, no questions asked? Or?
Well, there's no such thing as no questions asked, but the answer is most of the time insurance covers it. I mean, Medicaid won't let you do this, but Medicare pays for it. Most insurance will pay for it. There may be some pre-authorization you have to go through, but yeah, it's actually more expensive than that, right? You need to buy the device, $5,500, but you also need a cornea, which are like $2,000. So just those two material costs are going to be around $7,500, and that doesn't include, you put a contact lens in, the surgery, the ASC fees, all that. So it's an expensive surgery.
So do you do that in your surgery center, or do you have to take them to the hospital?
So for years we had to take them to the hospital, but we've recently been able to do them here and get paid. Oh, it's running. I didn't know. So this is, let me back it up, and then we'll end with this so I don't overstay my welcome here. How do I make it back up? Let's see if I go here. Okay, so this is someone who's had a keratoprosthesis. And I tell you, they have all sorts of complications. They've had a melt where fluid is leaking out around the keratoprosthesis. And so I didn't have a video of us putting one in to start, but this is us taking one out and re-putting it back in. You can salvage this very expensive device. So we're just doing like we would normally do a corneal transplant. We're removing the donor, the plastic piece is inside that donor. You'll see that better in a minute. All of the iris here is adherent to the back of the donor. So we're trying to get that. We're taking this old transplant, cutting it piecemeal apart. This plastic in the back, this is part of the device. This is the part they look through. All right, so now that is the device. We're going to disassemble it. The part you look through, which is called the optic. There's this retaining ring which sits against the back of the donor cornea that you're going to put in, and then the titanium ring locks those two together. So we're taking that locking ring off, and then we're trying to get these two pieces apart. So now they're apart. We'll get them all cleaned up, soak them in some antibiotic. While we're doing this, that eye is just open. And then we've taken a donor cornea, we've re-punched a hole in it, put the optic through it, we're putting the plate on that to sort of secure it, and then the locking ring goes back on to hold all that together. And then that device is picked up and sutured in place. So they have now, the problem with the one that was there before was this donor cornea that was holding it had a melt and it was leaking. So what we've done is just replace the donor cornea and then put the whole device back in the eye. And then the patient goes back to having vision. Uncommon. I mean, it's weird. I'm doing 2 of them on Thursday, but probably do 4 a year. It's not very common. Yeah. So remember, it's a really good question. What nourishes the cornea? Aqueous. So if you have a solid piece of plastic on the back of the cornea, aqueous can't get through and they always melt. So these big holes are to allow fluid to flow into the cornea. So it's the same thing. So for people who know LASIK, why do we care about epithelial ingrowth? If you have a big enough piece of epithelium that grows into the flap, the flap in front of that will necrose. It will die and slough off because the nutrition's not getting through because you've got a barrier to that nutrition. So really great question, clever question.
Will these patients
Yeah, so, I mean, their ocular surface is screwed up, that's why we're doing this. Yeah, they're difficult to maintain in the drier their eye is, the more of an issue there is. We keep contacts in them most of the time to try and keep moisture up against these and keep them healthy. I think my time is up. Let me see, I'm not going to go through this. These are just telling you that why it's hard. Conclusions, so, you know, with modern corneal surgery, we try and do the surgery might be more challenging, but we try and transplant only the part that's abnormal, and it really has markedly improved outcomes. It's markedly improved how quickly people heal and long-term survival in doing that. The deep anterior lamellar keratoplasty, where you remove all of the anterior stroma, eliminates that risk of endothelial rejection. You can never reject your own endothelium, and so again should make these patients see better longer. Endothelial keratoplasty allows us to get patients 20/20 vision without the higher order aberrations and give them really restore completely normal vision. PK is still done, but it's only when we have to, when all the different layers of the cornea are involved, and if all else fails, we do have plastic corneas. So that's the end, and if there are any other questions, I'm happy to. Yeah.
The air bubble, when you go through the surgery, they withdraw.
Yeah, your body just absorbs it. It takes 7 to 10 days, depending on how big the bubble is, for it to fully go away. Thank you. Who's up next?
After Ron.
Okay, you good?